Hi, good evening. So, without wasting much time, am I audible?
Yes,
Yes, sir.
sir.
Okay. Without wasting much time, we'll start with today's class. Okay. So, I think at least a few of them have attended my previous class.
Yes, sir.
Roshan,
Yes, sir.
oh, sorry that I could recollect only his name. I apologize for not able to identify others. He being quite regular, I am able to identify, no hard feelings. So slowly we'll get to know each other.
Okay,
Okay?
sir. Okay,
Yeah.
sir.
Hmm. Roshan, we had stopped at shoulder, I think.
Yes, sir.
Okay. So we'll continue the upper limb trauma part 2 with the clavicle fractures.
Clavicle fracture.
Okay. Clavicle fracture is usually treated by, go through
Figure of
that. Go through.
figure of eight.
Figure of
Yeah.
8 bandage.
Figure of 8 bandage. So no brainer, easy to answer, isn't it? Okay.
Yes, sir.
Something about clavicle fracture I will highlight today. Okay. So clavicle is also called as a collar bone. It is called as a collar bone.
Bone.
It is most common fracture both in adults and birth injury. Both in adults and birth injury. So it is divided into three parts: proximal third, middle third, and lower third. It most commonly injured by fall on outstretched hand. You might have heard this.
Yes, sir.
Okay. Foolish injuries. It is, of course, foolish to call like this, but it's very too easy to remember. Fall on outstretched hand. So, generally, clavicle fracture is secondary to fall on outstretched hand. So, this is a mechanism of injury. Most common is fall on outstretched hand. This one is directly when the patient falls on the shoulder. Third is if somebody or in road traffic accident there is a direct blow on the shoulder. These are common three mechanism of injury for a clavicle fracture. But most commonly it is because of fall on outstretched hand, and most commonly it fractures in the middle one third. To be precise, it is generally junction of middle one third and lateral one third. But it depends. You should read your choices very very carefully, whether it is lateral one third, middle one third, or medial one third, or junction of lateral one third and middle one third, or it is middle one third. So most common site of fracture of clavicle is in middle one third. To be
Yes.
precise, junction of lateral one third and middle one third. Okay. Okay. And next in common site is lateral one third fractures. We'll not get into that. Slowly, the most common management of clavicle fracture. Most common way of managing clavicle fracture is a conservative management. Remember this. Clavicle fracture is most commonly managed by a conservative management because fracture clavicle heals. Non-union is very rare. Mal-union is a rule. Malunion in fracture clavicle is a rule. Even if you just apply a figure of 8 bandage, clavicle heals without any problem. But there are certain indications for fracture clavicle to be treated operatively. Okay. So
Yes, sir.
one is
Lateral one third.
bilateral. Yeah, come again.
Sir, if there is lateral one third fracture.
Yes, lateral one third fracture. If it is bilateral clavicle fracture,
Yes, sir.
if it is floating shoulder, you remember this word. Am I
Yes.
audible?
Yes, sir.
Floating shoulder means there is a fracture of clavicle and fracture of glenoid. Neck. Neck of glenoid and clavicle on the same side. It is a floating shoulder. It is floating in air because what is connected to the axial skeleton, both the connections are lost. So glenoid neck is fractured and clavicle is fractured. Third is open fracture. Open fracture. It is a compound fracture. These are surgical indications I am talking of. We are
Yes.
treating managing clavicle fracture 90% of the times conservatively. These are the exceptions. Okay.
Yes,
If
sir.
there is a vascular injury, associated vascular injury, or if there is a clavicle fracture and piercing the skin, denting the skin, you again treat that operatively. These are the indications for surgical management. Understand?
Yes,
Yes,
sir.
sir.
And if conservatively treated, if doesn't unite in non-union, you have to treat it surgically.
Surgically.
Yes, these are the indications for fracture clavicle to be
Surgical.
operated. So, how do any fracture for that matter? Please remember in orthopedics, there is only common way of management is either nailing or plating or K-wire. Remember this. There is no
Yes.
big brainer required on this. So, clavicle fracture, there is no medullary cavity. It is a flat bone. So, you will manage with plate. You will manage with plate.
Plate.
Plate and screws are the common fixation device. Another one is intramedullary K wire. Will not get into that. That is enough for you as of now. Okay, this some details of clavicle fracture is essential for you to be operating. Middle one third clavicle fracture is figure of 8 bandage. Lateral one third clavicle is
Surgical.
Surgical.
no surgical. Correct. Some can be managed by AC joint undisplaced lateral AC joint dislocation or subluxation, lateral one third fracture undisplaced can be managed by Velpo or Robert Jones bandage. If you can remember, it will be great. These are middle one third figure of 8, lateral one third when you are treating conservatively. You are correct, 100% correct. Lateral one third you are treating surgically. But if the patient fits in conservative management, it is not figure of 8 bandage, it is a
Robert
Velpau band,
Johnson or Velcro.
Velpau bandage. Okay. This is one diagram you can remember easily. This is a commercially available clavicle brace. This is you can make it customized. Simple roller bandage. If you go on tightening, you can do a figure of 8 bandage. There are plenty of ways of doing a figure of 8 bandage, but this becomes adjustable. This is not adjustable. Okay.
Okay, sir.
So this is what I wanted to show you some pictures. Most common
Middle
site
third.
of clavicle is middle one third. Next common is lateral one third. Ways of management is conservative for this, operative most often for this. Fixation device, clavicle fracture middle one third is plate and screw or intramedullary K wires. Okay.
Yes, sir.
Next, we will go to proximal humerus fracture. Proximal humerus fracture. Okay.
Yes, sir.
I will briefly explain you. proximal humerus fracture. The classification is Neer's classification. Please remember this. Try hard and try to remember this. Neer's classification. Very, very easy. Very, very easy. Neer's four-part classification. Why
Yes, sir.
four-part? Why four-part is the proximal has four parts. One is the head, one is a greater tuberosity, lesser tuberosity,
Yep.
and shaft of the humerus. Okay, these are the four parts. The proximal humerus can fracture in four parts, but not always. Not always. It can be simple two-part fracture, it can be three-part fracture, or it can be a four-part fracture, or it can be a four-part fracture with dislocation. Remember this. Okay. Before
Yep.
that, so most common proximal humerus fracture are seen in elderly. Remember this. Most commonly, the proximal humerus fracture are seen in elderly. Okay, please remember it is very easy. You remember the proximal humerus anatomy and the parts, you can easily convert that into Neer's classification. That is a four-part classification. So
Yes,
again,
sir.
two-part can be surgical humerus or only GT fracture or only LT fracture. Two-part can be head of the humerus and GT or head and of the humerus and LT. So it is a simple mathematical probabilities. So actual X-rays I am showing you. This is a two-part fracture. This is a two-part fracture. Look at this. There are three parts, isn't it?
Yes, sir.
GT, head of the humerus, and the shaft. This
Yep.
is three-part fracture with dislocation. Okay.
Okay, sir.
Why I wanted to show you this, some X-rays or some things are most commonly proximal humerus fractures are seen in elderly patients, and most of them are treated conservatively in the form of sling or collar and cuff. There is you remember this word. Cuff is handcuff, collar is collar. Okay, collar and cuff. This is how you will remember collar and cuff. This is a sling or arm bandage. Okay, before that. So all the knees fracture classification you need not operate if it is displaced more than 1 centimeter, if the angulation is more than 45 degrees. You might find it difficult to understand. I will explain. Please listen carefully. See, here the fracture is there, but it is not displaced. Look at
Yes,
this
sir.
X-ray. All the fractures are displaced in a different direction. So this is indication for surgery.
Surgery.
Here the fracture is, there is a fracture, but it is undisplaced. When do we call there is a fracture? Displacement or indication for surgery in proximal humerus. Please remember, if the displacement between two, separation between two fragments is more than 1 centimeter and the angulation is 45 degrees. If any of this character is there, you will advise surgery. Please remember this. Okay, we'll go and most important thing again I want to mention is in a four-part fracture. So two-part displaced fracture, three-part displaced fracture, you do open
Surgery.
reduction.
Internal.
No, displaced I am telling. I am, please listen to my words very, very carefully. Two or three part displaced fractures. Open reduction, internal fixation.
Fixation.
See, whenever there is a displacement, you have to reduce it. It's very common sense in orthopedics.
Yes.
Yes, sir.
Displacement, you have to reduce it. So how do you reduce? You can do either a close reduction or open reduction. Whenever you are doing nailing, it is a close reduction. More oftenly, you do nailing, close reduction. You do open the fracture site if you are not getting a close reduction. That time it is open reduction. So once you do open reduction, you have to fix it, isn't it? So you have to fix it internally. So 2 or 3 part fracture displaced, you do open reduction internal fixation. Focus on this X-ray. This is one example of open reduction internal fixation with plate. But when it comes to 4-part fracture, the chances of this fragment going for AVN is very, very high.
Yes, sir.
See, how does your head get blood supply? Blood supply to the head is either from GT or LT, because the head is intra-articular, covered by the cartilage. It doesn't get the nourishment from the joint. The blood supply has to get from the blood vessels entering from the GT or LT. But when there is a 4-part fracture, when there is this part, it can very easily go for a avascular necrosis. Please remember this. To uncomplicate or to make it simple, in a 4-part fracture, when chances of AVN of the head is very high, consider replacement. Easy. All 2-part, 3-part fracture, undisplaced, conservative management; displaced,
Open
operative management by fixation, open reduction. If there is a 4-part fracture where you can fix it, but chances of this head going for even is very high, so better to replace it. Again,
Yes.
replacement, there are two types: total shoulder arthroplasty or reverse total shoulder arthroplasty.
arthroplasty.
Please concentrate on these words. Please concentrate on these words. Total shoulder arthroplasty or reverse total shoulder arthroplasty. So what is total shoulder arthroplasty? So you replace the head, you replace the glenoid. Humeral head by the metallic head, glenoid cup by a plastic cup or a polyethylene cup. So that is total shoulder arthroplasty. So what is reverse total shoulder arthroplasty? Where that picture is not there. I'll come to that a little later, so you can understand better. These diagrams are total shoulder arthroplasty. I will come to reverse total shoulder arthroplasty after I show some pictures. Okay, some questions. Proximal humerus fracture, which has maximum chance of avascular necrosis.
4 parts.
Quick.
4 parts.
Treatment of choice of fracture of humerus in 70-year-old.
Arthroplasty.
Arthroplasty.
Treatment of choice for fracture neck of humerus. This is humerus. Please remember. This is humerus, not the femur. So, fracture of, the fracture will be here. Fracture, treatment of choice of fracture neck. Proximal femur has 2 necks. Please remember this. This is an anatomical neck. This is a surgical neck.
Surgical.
This is an anatomical neck. There is one more called embryological neck. We'll not get into that. Please remember anatomical neck or a surgical neck. So whenever they are calling for fracture neck of humerus in a 70-year-old, that they mean surgical neck. Okay, the vascularity of GTLT with the head is intact. So no chance of AVN. So what you want to do? I have given enough clues now.
Open reduction. Internal.
No. This one. This is the answer. Analgesic with simple triangular sling. Whenever they mean fracture neck of humerus, They are not mentioned about the displacement or dislocation. Most commonly, I told you, they happen in elderly. You can treat them conservatively. Please remember, this question is not at all tricky. Treatment of choice of fracture neck humerus, I mean surgical neck, most commonly treated conservatively. Okay? Any doubts, you can please ask me. Okay.
Yes, sir.
Then we will go to diaphyseal humerus fracture. Diaphyseal humerus fracture. There is nothing much to ask, or not many questions are asked. Generally, the questions asked are humerus fracture is associated with one particular neurovascular injury. Neurovascular, I mean, it need not be vascular or it need not be neurological. It can be combined or it can be individual. So, most commonly, can anybody tell me what is this? This is Holstein fracture. Holstein Lewis fracture. Don't get nervous. There is nothing big deal in this. Fracture of
Lower
lower
third.
third of humerus, where this lower third of humerus, where this part impinges on the radial nerve. Okay, so how the radial nerve comes? It comes from
Spiral cord.
axilla, it crosses the spiral groove in the triceps spiral groove from medial to lateral, where from lateral it enters into the pierces the intermuscular septum and goes posteriorly. So in lower third humerus there is a spike which can cause a wrist drop. Remember this. So I'll come to few questions later. These are some way of fixing a humerus fracture. Not going to that. All of the following are indication for surgical management except, I mean, humerus fracture. We can make out. Fracture in elderly.
Yes, sir.
Renal involvement. Read the question carefully. All of the following are indication for surgical management except.
Fracture in elderly.
Very easy question.
Fracture in elderly.
Yes. Fracture in elderly, you can treat conservatively. There's nothing much to be discussed. But discussing on some of the choices available, I want to explain you. So if there is in casualty, there are nowadays clinical based questions, which is the flavor of most of the examination. So in a casualty, if you get a patient, my audio is clear.
Yes, sir.
Yes, sir.
Hello. Okay. In a casualty, you receive a patient of fracture humerus. You have to examine radial nerve. Radial nerve, how do you examine? Simple. You ask for a dorsiflexion.
Yes, sir.
Okay. There can be already a radial nerve involvement, or you want to fracture. Whenever there is a fracture, you immobilize with a slab, isn't it? So you manipulate. After manipulation, sometimes they develop a wrist drop. So what is important is when you receive the patient, you have to check distal neurovascular deficit. Any fracture which is close to the vascular structure or neurological structure, you have to examine deficit. So you feel for the pulse and look for a corresponding nerve which can be affected. So in posterior dislocation of hip, what do you ask? Say suppose there is a question in a casual busy casualty, the patient comes with a fall from the height with the hip with the leg flexed, adducted, internal rotated. It means it's a dislocation. So what is that one examination you want to do? Dorsiflexion, because there is a possibility of sciatic nerve will not deviate. I mean, I just for a completion I've mentioned that pathological fracture invariably you have to fix. Pathological fractures in tumor sessions I have taken earlier. So it can be multiple myeloma, or it can be METS. Why do you fix in the pathological fracture is to reduce the fracture pain, to improve the quality of life of the patient. Vascular injury, of course, there is no other way. You have to immediately open. Multiple fractures, it is always an indication for surgery. Even if there is a clavicle, we mentioned about surgical management and conservative management of clavicle, isn't it? So if there is clavicle involvement along with the hemothorax, clavicle management fracture along with other fractures, such fractures we treat surgically. So most common cause for non-union of shaft of humerus. Very easy.
Hmm.
Communicated.
So any fracture, for the fracture to heal, it has to be in alignment. One, and it should be compressed either by a plating or by kneeling. So there should be a compression at the fracture site for the union. Comminuted fracture is not the commonest cause for a non-union, not the open humerus. It is a distraction of the fracture. If you are not compressing the fracture, it is the most common reason for a non-union of humerus. First to appear among the ossification center. Okay, we are heading to elbow. Before that, I will briefly explain about acromioclavicular dislocation. I will finish that. Only one or two questions I have found in the past exams. Acromioclavicular joint dislocations. Not much. There are 6 types. Don't break your head too much on this. This is not a very high yielding topic or whatever. Acromioclavicular joint dislocations are classified by Rockwood. If you can remember, well and good. Please remember 1, 2, 3 it is conservative management. 4, 5, 6 it is surgical management. Won't really get into much detail. Just for completion, I wanted to mention acromioclavicular joint classified into 6 types. First 1 to 3 conservative management, 4, 5, 6 surgical management. Okay.
Yes, sir.
Hello.
Yes, sir.
Okay. So we'll go to elbow. We'll go to elbow. So ossification center around the elbow. Any mnemonic? Anybody remembers?
Cryotic.
Huh?
Cryotic.
Crito or cryoto.
Radial heads.
So 2, 4, 6, 8, 10, 12. Very easy to remember. It is a worldwide accepted mnemonic. I'll not get into much this one. So if you remember this mnemonic, to answer this, it is capital. Crito 2, 4, 6, 8, 10, 12. But remember, you most often know what is Crito, what is the age or time duration, but you forget what each alphabet means. C is capitulum, R is radial head, T is trochlea, O is olecranon, I and E, internal or medial condyle, E or external or lateral condyle. You should remember. You should remember this. You will remember the mnemonic, but you will for sometimes forget the expansion of the first letters of the mnemonic. So posterolateral anconeus triangle is formed by
Sir, olecranon process and um, medial epithelium and lake of the radius.
First it is a lateral. Remember this posterolateral.
Lateral.
Okay.
Yes, sir.
So
Olecranon, lateral epicondyle, and neck of the radial.
it goes off without any problem.
Yes, sir.
Okay. Head of radius, lateral epicondyle, olecranon. So here again medial, this is gone. This is gone. Now you are left with only two choices: head of radius, neck of radius, lateral epicondyle, olecranon, olecranon. So what are the choices to remain? At times you have to look into the choices. You can answer most often by ruling out. Of course, you have to be careful in negative marking. So this is the correct answer. So Anconius triangle is found by the head of radius, lateral epicondyle. This is the head of radius, lateral epicondyle. This is
And
olecranon.
epicondyle.
Okay, this is the triangle. This is the triangle. This is found. The floor is found by Anconius muscle. Will not get into that much. Okay, this one I wanted to show so that you will remember. Creto. Here he has given as 1, 3, 5, 7, 9, 11. In some books it is 2, 4, 6, 8, 10, and 12. What is important is not the exact age. It is the order of the appearance of the physis. Order of the appearance. See, not in one thing you please remember, most of our PGs also do not know. There is already a bone, everything is formed, but it is cartilaginous. It is not seen on X-ray. So what does this means here a small ossification center forms. This cartilage model you don't see on X-ray. What you see is only the specks of ossification. So what it means is already a elbow model will be there, bone model will be there, but it is not seen on X-ray. These are appearance on X-ray. These are appearance of ossification center on X-ray. Remember this. Already elbow is there. Every bone is there, but it is in a cartilaginous form. You see ossification center because there is a bone formation which is a radio opaque on X-ray you see. So why this is essential is especially in the age estimation. Okay, will not go there. And remember this picture around the shoulder, around the wrist, around the knee.
18.
These are the growing ends. These are the growing ends. So they fuse late with the bone. The physis fuses later with the bone. So elbow, hip, these are the non-growing ends. Why this is important? You please remember this. You please remember this. These are the growing ends, wrist, shoulder, elbow, knee. Why this is important is one is in age estimation, second is in if there is any osteomyelitis of these ends of the bones. It can damage the growing end. So it can affect the length of the limb. Please remember this. It can affect the length of the limb, and growing end contribute to 80% of the length of the limb. If there is a say 10 centimeter whatever, this is hypothetically I am telling, if there is a 10 centimeter segment, 8 centimeter is contributed by these growing ends. So what is importance of these growing ends is they fuse late, they contribute to the greater length of the limb, and if they are affected in infection, they affect the limb length, they cause limb length discrepancy, and they are generally the sites for bone tumors. Okay.
Yes, sir.
Patient of supracondylar humerus fracture is unable to flex interphalangeal joint of the thumb. Which nerve is most likely injured?
Anterior interossei, sir.
Anterior introtional.
Very good. Because you are remembering, you have answered a lot of such questions, I guess. Okay.
Yes, sir.
In unable to means FPL is affected. One more
First,
thing there. First, FPS is flexor pollicis. FPL, sorry, FPL, sorry. FPL, flexor pollicis longus. Okay. The nerve affection in supracondylar humerus fracture is there's one more mnemonic. I think all of you must be aware of this. In
Amru.
this order, in this order, please remember it is in this order: median nerve, radial nerve, ulnar nerve. A is anterior interosseous nerve. Please remember, anterior interosseous nerve is affected in supracondylar fracture. Pin is posterior interosseous nerve is affected in Monteggia fracture. Monteggia fracture. I'll come to that a little later. Okay. Something about supracondylar fracture. Supracondylar fracture is generally seen in 5 to 8 or 5 to 8
Yes.
years. More commonly, of course, naughty male kids for all that. Most importantly is there are broad two-type classification. Broad two types of classification: flexion type and extension type. Up to 98% is extension type. Flexion type is only 2%. Don't try to remember, mug up this percentage. It can vary from books to books. But remember, extension type is more common. Extension type is more common. So again, extension type, the displacement. Whenever you see, one beautiful thing about orthopedics is you can imagine a lot of things looking at yourself even in exam center. Medial, lateral, joint movements, muscles, tendons. You can demonstrate, or you can very well do it then and there. Okay. Why this is essential is most of the times you try to remember whether it is posterior, lateral, medial. Don't try to remember this. You can then and there in the exam hall, you can orient yourself by looking at your own parts of the body. Extension type and flexion type. Extension type, again, there are two types: posterior lateral, posterior medial. There's no big brainer in this. Extension type is again a fusion injury. Don't try to remember everything. Extension type is whenever a patient falls and the distal part, see, extension type or flexion type depends on any fracture for that matter in orthopedics is described by the direction of displacement of distal fragment. Mark my words, listen carefully. Fractures are classified, or dislocation is classified by the direction of displacement of distal fragment. Okay, no confusion in this. So supracondylar fracture, extension type, flexion type. Extension, again, it can be, extension is posterior, it can be lateral or it can be medial. This is broad classification. So our posterior-medial displacements are again further classified by Gartland's classification. Don't try to remember the name of the classification. It is divided into three types: type 1, 2, and 3, depending upon the degree of displacement. How much is the degree of displacement? Look at this very carefully. Type 1, type 2, type 3. Type 1 can be undisplaced or there can be a minimal angulation. Type 2, there is a posterior contact, there is no anterior contact. Type 3, complete loss of contact of fracture fragments. Simple. Try to remember only this one. Don't try to remember Gartlands and other things. Okay, before that. So, what is the... Okay, I will come to this. I'll come to that later. Okay. Supracondylar fracture, most common fracture in the children is supracondylar fracture. You remember certain things about supracondylar fracture. Most common, it is most commonly maluniting fracture. Most
Yes, sir.
common complication of supracondylar fracture. Most common complication of supracondylar fracture is malunion. Please remember this. Of course, there can be vascular complication, there can be neurological complication, there can be compartment syndrome, VIC, and
Yeah.
so many other things. But most common complication is uh,
Malunion.
malunion. Remember that. Then we'll come to that later. Certain things. So, what is this?
Sir, Beres.
Cubitus
Varus.
varus.
Beres.
Deformity.
Cubitus varus deformity is secondary to supracondylar fracture.
Yes, sir.
As I said, supracondylar fracture.
Gunstock
Gunstock
deformity.
deformity. See, look at this. Gunstock is the long rifle, the back portion, the hind portion is gunstock. Look at this. It
Gunstock
looks like a
deformity. Yes.
rifle. It is a gunstock
Gunstock
deformity.
deformity.
So cubitus varus is also called as gun stalk deformity. So you should remember certain things. What is normal? Just a minute.
Carrying angle.
So what is the normal carrying angle? Carrying angle is nothing but okay.
Angle of the arm and angle of the forearm, sir.
Angle of arm and forearm is, instead of that you should tell the angle between the long axis of the arm and long axis of the forearm.
Yes, sir.
Okay, away from, see, valgus and varus, I don't know, most of them can easily remember, but how I used to remember is, if the deviation is more towards the wall, valgus, towards the wall, valgus. Even in knee also, genu valgum, towards the wall, valgus. Away from the wall is varus. Very easy. Of course,
Yes.
carrying angle is more in women to accommodate the wider pelvis. That is a way of evolution of the or gender between the evolution of the morphology. So increased carrying angle is valgus, decreased carrying angle is varus. So how do you treat? So cubitus varus is the most common complication of supracondylar fracture. We have
Yes, sir.
come to remember that. So what do you do? What is the problem? It is more of a cosmetic problem.
Yes,
Yes, sir.
sir.
You see many people, at least one of the relation, if you take distant relation, one few of, at least some of our medical students in their own relation or neighborhood, they will see one cubitus virus in adult, most common. You see that the way they either try to hide by the long sleeve, but whenever they are wearing half sleeves or sleeveless, you see that they are cubitus virus. Cubitus virus is more of a cosmetic deformity. It doesn't cause any functional disability. Remember this. Any fracture which is malunited more commonly or more likely can cause a functional disability. But cubitus varus or gunstock
Cosmetic deformity.
is more of a cosmetic
Deformity.
deformity. So it need not be treated. It is treated only if the patient bothers you and treated after the closure of the physis, because the chance of recurrence is very high. I'll come to that later. Cubitus virus. So, what is the preferred treatment of the cubitus virus?
Lateral wedge osteotomy, sir.
Yes,
Lateral close wedge osteotomy.
very good. See, what is open wedge or closed wedge? Okay, the lateral closed wedge osteotomy is also called as modified French osteotomy. We'll come to. I'll show you one picture. See. This is, of course, don't bother about this lateral medial varus valgus. So what is wedge? Wedge is, one triangle. You put it for a
Yes, sir.
wedge. In airport, you see that wedges to prevent the plane sliding on the tarmac. So this wedge, this is a triangle portion. So either you remove this wedge and make it straight. This is close. You are closing it by removing wedge of the bone. Or you can do otherwise, just cut the bone and make it straight. See, I'll draw this picture. Okay. So what I will do, it applies for both varus valgus, medial lateral. I am not trying to mention that. I am just giving the principle of wedge osteotomy, open wedge or closed wedge. There is a deformity like this. So what you do, you remove this much bone
Lateral
and
portion.
close this. This is a closed wedge. Or also what you can do, there is a deformity like this. What you do only one cut like this and you
Put it.
open. So this is a open wedge osteotomy. What are the advantages? In open wedge osteotomy, you achieve a length. You get lengthening. If there is a limb which is short, you get lengthening. You do open wedge. But in closed wedge, you will remove some part of the bone. Here you are not removing any bone. Open wedge, you are not removing the bone. In
Yes,
closed
sir.
wedge, it will cause shortening. So medial lateral, correspondingly, you know whether in valgus, varus, whatever you want to do. So it is varus means you do lateral open wedge. If it is a varus, you want valgus, isn't it? Medial open wedge or a lateral close wedge. You can imagine that. You can imagine yourself on the your limb. Don't try to remember this, but you try to understand the principle. In a busy casualty, patient comes with upper limb fracture. According to the priority, which of these have to be reviewed by a ortho resident? Now you have passed your internship, you are posted in a busy casualty. So you see a patient who comes with a upper limb fracture. So what you do? When you will call ortho resident, read this. Very, very interesting question. Of course, it has appeared in one of the exams. Only such, henceforth, probably such questions will be asked.
First options.
So, okay. Delayed capillary filling in the fingers of the involved limb. Very, very important. It means there is a vascular compromise.
Yes, sir.
Intra-articular fracture, already there is a fracture, nothing emergency needs to be done. Abrasion or open fracture more than 10 centimeter, of course it requires immediate attention, not urgent attention. Having weakness of extensors, again it can be because of neuropraxia. So most urgent attention required is delayed capillary filling in the fingers, means there is a vascular compromise. About supracondylar fracture, what is true? Flexion which one is answer? If they can quickly, anybody can answer.
Malunion causing gunstock deformity
Malunion
most
causing
common.
gunstock deformity is most common, sir.
Very good, very good. So in supracondylar fracture in children, if radial pulse is absent, what is next? Remember children, supracondylar
Open
fracture.
duction.
Yes. If there is a
Sir,
radial
open.
absent, you don't go
Interface.
for brachial artery exploration. You do close reduction. You remember that completely displaced supracondylar fracture? So you try and reduce the fracture. Look for the appearance of the pulse. If you get the pulse, that is a great relief. You don't have to call a vascular surgeon or you plan anything further. Try to reduce the fracture, look for the pulse. If it appears, great, half the job is done. Limb is not at risk any further. Then you can plan for a definitive management.
But the
So,
radial pulse is absent here.
yes,
So radial pulse is absent.
when?
In supracondylar humerus fracture in children, if radial pulse is absent, so sir, open reduction cannot be done.
No, it can be done. But see, imagine open reduction means the child NBM status you should know, whether
Okay,
the
sir.
child can be taken for surgery you should know, all those things. So taking for surgery might be delayed for 4 to 6 hours. You
Okay, sir.
cannot wait for that time. So you manipulate that. You do a close reduction. Look for the
Okay.
pulse. If it appears, then think of reduction. Whether the reduction is good, just put the plaster, you send. If the reduction is not good, you do open reduction.
Okay, sir.
Understand?
Yes,
Here,
sir.
the question is not about close reduction, open reduction. As soon as you see a fracture with absent pulse, reduce the fracture. If the fragment was pressing on the artery,
And
you
wait for
reduce
the
it,
reappearance.
you get a pulse, half the job is done. Then open reduction depends on whether the alignment is acceptable or not. If the alignment is acceptable, pulse is already there, then you are done with the job. You don't subject the patient to vascular surgery. Okay, I'll come to that algorithm later. So vascular injury in a supracondylar fracture in a child. So pulse is present, pink hand. Pulse is absent, pink hand means the capillary filling is there. Pulse is absent, white hand means capillary filling is absent. Remember this. You have to categorize the supracondylar fracture in three. Pulse is present, capillary filling is adequate. Yes. No vascular injury. It is ruled out. Just put a slab, splint it, then call orthopedic resident or do accordingly. Pulse is absent, capillary filling is delayed. So what you do? You try and manipulate and again feel the pulse and you immobilize. So depending whether the pulse appears or does not appear, we'll take that little later. So both pulse is absent, capillary filling is absent. Immediately you will have to rush for vascular procedure. Remember this. So this is what I was mentioning. It is displaced like this. There is no pulse. Capillary filling is delayed. You manipulate in casualty. You get good capillary filling. Pulse is absent. Pulse is not important. Capillary filling is very, very important. This is how you fix the fracture. What is seen on X-ray with the posterior dislocation of the elbow? Very easy.
Coronary process inferior.
Coronary process is posterior to the humerus.
Yes, sir. Posterior, sir.
So it is dislocated posteriorly, isn't it?
Yes,
This
sir.
is a coronary
Yes.
process. It is displaced posteriorly. So in elbow dislocation, this one chart I could gather somewhere. Please remember this. These are some screening tests you can do. Whatever AMRU, interosseous nerve, medial nerve, radial nerve. Whenever you see in casualty, these are some hand signs you have to look for to know whether the nerve is intact. Benedict sign or peace sign for ulnar nerve. If the patient can do like this, if the attitude is like this, if you ask the patient to do thumbs up, he is able to do, radial nerve injury is ruled out. If you make a fist, patient can make a good fist, medial
Mid-
nerve is intact. If he can do a OK sign means tip of index to tip of thumb. They should be able to touch. This means what? FPL is working and flexor digitorum profundus is
Profunda
working.
working. Yes, sir.
Both are working. OK sign means anterior interosseous nerve is intact. Of course, this is again one more similar picture. But remember this. You please remember this. You can thumbs up sign. Wrist drop you can see other things are there. This is just in hand signs. We are only limiting ourselves to the hand signs. Okay, will not go into this. Following fractures are known for non-union, except
Except sir, fracture neck of
Read carefully.
Supracondylar fracture of humerus.
Yes. Supracondylar humerus is
Malunion.
malunion, isn't it?
yes, sir, malunion.
This is intraarticular. This is intraarticular. And both are risking for AVN. I'll come to that little later. Lower half of tibia, very subcutaneous bone, no muscle covering, hence non-union. Supracondylar, most common is malunion. Okay? Read the question carefully. Read the question carefully. Lateral condyle fracture again is common in children. Certain things about lateral condyle fracture, please remember. It is classified by Milch. Will don't try to again remember. This is type 1, type 2. Type 1 is type 4 epiphyseal injury. Type 2 is type 2 physeal injury. I don't know whether you can recollect, but there are some trick of remembering this. Type 1 lateral condylar is equal to type 4 epiphyseal injury. Epiphyseal injuries are classified by Salter Harris. You should remember this name. This is very, very common undergraduate question. Salter Harris. Type 2 lateral condyle. This type 1 and type 2 I am talking of lateral condyle fracture. Type 1 is type 4 Salter Harris. Type 2 is type 2 Salter Harris. Salter Harris I will not cover now, but try and remember easily. It is very, very easy. Okay. In some books I just try to explore. The 1 into 4 is 4. 2 into 2 is 4. I don't know what logic it makes, but this is how it helps in remembering and recollecting. Type 1 is type 4, type 2 is type 2. This is very essential. It will invariably appear. Certain important things of lateral condyle fracture is it is an intra-articular fracture, and most common complication of lateral condyle fracture, unlike supracondylar fracture, is non-union. Okay.
Yes, sir.
Is taking a practical examination, but I will come to some practical tips. Supracondylar malunion, lateral condyle non-union.
Non-union.
Sorry. Non-union is lateral condyle. Malunion is supracondylar. There are certain important terminologies. You will come to that. Malunion supracondylar cubitus varus, non-union lateral condylar cubitus valgus. Please remember
Yes,
this.
sir.
If you compare, you will easily remember. So there are various ways of remembering this. One is mnemonic, second is visualization, third is remember one opposite. The contrast would be meaning something else. Okay.
Yes,
Cubitus
sir.
in supracondylar fracture, non-union lateral condylar cubitus valgus. And one more thing is non-union lateral supracondylar, it is progressive. Supracondylar malunion, it is non-progressive. It is again no-brainer. Malunion supracondylar cubitus varus, non-progressive because it is away from the physis. It is not involving the growth plate. So it is static. It doesn't progress. Non-union lateral condyle, it involves the lower end humerus growth plate. So growth disturbance is there, hence it is progressive. Please remember this. Of course, these three types is depending upon the displacement. I will come to that. If you can easily remember, see lower end humerus, this capital is there like this. Type 1 is up to here. Type 2 is up to here. If you can, lower end of humerus, this is a capitulum, this is a trochlea. Type 1 goes in between the capitular trochlear groove. Second type Mills goes in the trochlear groove. Okay. All are true regarding fracture of lateral condyle humerus except quick.
Second options.
Yes, this is in supracondylar fracture.
Supracondylar.
Yes. Radial nerve palsy, remember, your ulnar nerve of medial condyle. Tardy is what? Tardy is tardy is
Slow.
all slow. The progress is very slow. Ulnar nerve palsy happens, but it is slow. It can be slow or it can be late. Tardy, you remember this. Okay. So as the cubitus valgus goes on increasing, you develop the ulnar nerve palsy. A late onset or a slow onset ulnar nerve palsy is seen in lateral condyle fracture. A child following fall on outstretched hand presented with tenderness and crepitus over lateral condyle with elbow instability.
Non-unions.
Yes. Which fracture requires open reduction in the children?
Lateral condyle.
Lateral condylar fracture of
Very good. So this one important thing again I want to mention. You remember these photographs, then you will recollect lot of things. So there is a triangle relation. Medial epicondyle. This is if I am drawing this picture. Lateral
3 point
epicondyle. Medial
3 point
epicondyle. 3 point. This is olecranon. So you should know this. So if there is a supracondylar fracture, there is no disturbance in this. This is an isosceles triangle where these two sides are equal. Some books have given equilateral triangle, but don't really try to learn geometry in this. There's nothing much. What is important is you should be able to compare this to the normal unaffected side. So some people isosceles, they say, some people equilateral, don't get into that. But they should be symmetrical. They should be mainly symmetrical. In supracondylar fracture, 3 point bony relation is not affected. When it gets affected, if there is a lateral condyle, if there is
elbow
a
dislocation.
if there is a elbow dislocation, or if there is a olecranon fracture. If it is whatever, if it is affecting this, the points, bony points causing a triangle, then it is affecting. So in one more important thing about posterior dislocation of elbow is it is reversal of triangle. Here it was like this. So this triangle relation is in elbow is in 90-degree flexion. Remember this. 3 bony points form a triangle in 90-degree flexion. In extension, they form a straight line. So in 90-degree flexion, they form a triangle. It is unaffected in a supracondylar or a malunion supracondylar fracture. There is a reversal of triangle. This reversal of triangle, this becomes olecranon. This, of course, lateral epicondyle and medial epicondyle. This is seen in posterior dislocation of the elbow. You please remember this. Posterior dislocation of elbow, there is a reversal of the triangle. This was olecranon. In normal, this becomes a olecranon. Okay, this one thing I wanted to mention. Look at this. This is medial, this is lateral, because this is olecranon, this is radial head. So medial means cubitus varus. What they have done? They have cut the bone here. This is the, oh sorry. Okay. What they have done? This is axis of the humerus. This is axis of the forearm. There is a varus now. So what they have done? They have cut this, opened that, corrected this, and put a K wire. This is a corrective osteotomy or corrective osteotomy for a cubitus varus. Compartment syndrome. Shall we continue for 5 more minutes?
Yes, sir.
I'll continue for 5 more minutes, okay? So earliest sign of compartment syndrome. Quick. Very
Sir,
easy.
that is
Pain on passive stretch.
Yes, pain on passive stretch is earliest
first.
sign. So
Yes,
what
sir.
is compartment syndrome? Increase in
Compartmental
inter-
pressure.
interstitial pressure. Increase in interstitial pressure more than 30 millimeter hertz. Of course, there are indication for compartment release or fasciotomy. I'll come to that later. More than 30 millimeter mercury in a normotensive patient. Normotensive patient. If the patient's BP is normal, he is not hypovolemic shock, he is normotensive, is maintaining blood pressure. That time, if it is more than 30, you have to operate. Immediately you have to do fasciotomy. So first, there is the increase in interstitial pressure. Capillaries collapse. Then collapses the veins. Then collapses the artery.
Sir,
Depending when the yes. Hello. Okay.
more than 30 millimeter edge.
30.
Yes, sir.
So whenever interstitial pressure increases, there is a capillaries which collapse. You see decreased blanching, capillary filling. Then when the veins collapse, you see there is lot of swelling. Blood keeps coming in the artery, but it doesn't go back because veins are collapsed. So huge swelling. Lastly, the arteries gets compressed. That time you see pulselessness. So it is very, very late. If you are seeing pulselessness, it is very, very late. Earliest sign of compartment syndrome is it is like a myocardial infarction, the infarct pain. So you are stretching the passive stretching of the wrist joint in a volar compartment syndrome or a forearm compartment syndrome if there is a pain. If there is a rest pain, a fracture is painful when it moves. But if there is a pain which is not explained by the fracture continuously, if there is a pain, it again indicates impending compartment syndrome.
Sir, Walkman ischemic contraction also there's pain on passive stretch is the earliest sign.
Yes. You should understand the difference between
Yes, sir.
compartment syndrome is a acute setting.
Yes, sir.
It is in an acute setting. BIC
BIC
is
is the
a
complication of the compartment syndrome, sir.
BIC is a complication of a compartment syndrome. Remember this. Workman's ischemic already contracture.
Actually, yes.
Earliest way a nurse can detect the development of compartment syndrome in a patient with a cast. See, compartment syndrome can be because of huge hematoma, closed fracture with hematoma,
Decrease
tight
response to analgesia.
compression bandage. Yes, decreased response to analgesia. Tight compression bandage, huge hematoma compressing there, or vascular compression. In fasciotomy, all of the following are cut except
Muscles.
easily. Good. Typical picture in established workman's contracture. Remember this. Very, very. You can. This is one I was mentioning. See, in such questions, you can as well do it on pronated wrist flexion, thumb abduction, MCP flexion. When you
Sir,
do
except
this in your own upper limb, then you can easily. Yes, except it is except yes. Sorry, it is
Sir.
except.
Thumb abduction. Yes, sir.
Thumb is adducted. Remember, thumb is adducted.
Yes, sir.
Okay, myositis will cover later. Some more things about fascia workman's ischemic contracture I will tell. Management of workman's ischemic contracture I will tell. Okay. Max page is an operation which is done. Max page.
Max Page.
See what happens in workman's ischemic contracture. The muscles lose flexibility. Muscles will cause necrosis, it becomes fibrosis, they lose the stretchability, they lose the contractility, it becomes a tight cord. So, when most commonly affected muscles are flexor digitorum profundus
Profundus.
or deep compartment in the forearm and posterior compartment in the leg. Remember this. So, what happens? These muscles become small. These are a multi-joint muscles. The flexor muscles of the finger cross the elbow, wrist, MCP joint and IP joints. When these become small, it becomes like a bow, isn't it? It becomes a bow. Our bone is straight. You can't do anything with the bone. Bone, this is radius or ulna. This becomes this. So what happens? This is a wrist. This is a hand. These are the tight cord. Your hand becomes like this. The wrist, finger. So what this is what I was. It becomes a bow like this. This is a forearm. This is a wrist. This is a MCP joint. But these muscles stand out like this, prominent, neither contract. So what you have to do? Either you have to shorten the bone. You do the radius and ulna. So that time both become equal. Or you release this. Releasing of common flexor origin is called as max page operation. So bone muscles are small, bones have become flexion. So what you have to do, either you do the forearm bone shortening or lengthen the muscles by releasing the common flexor origin. This is one way of doing a this you please remember. I'm talking of workman's ischemic contracture. Remember this, it is a complication how we are managing complication. Max page operation is a operation for a workman's ischemic contracture, whereas in fasciotomy what we do, you do a fasciotomy. What has happened here? Here interstitial pressure is raised, but
Increased.
skin and subcutaneous is tight. It is unyielding, isn't it? So if left alone, what will happen? The muscle will become necrosed. So what you do? You do a skin incision like this. You cut the skin. Most important is deep fascia. You have to cut the deep fascia. You know how the cross section of the forearm, isn't it? Radius ulna, interosseous membrane, subcutaneous tissue, and there are the compartment deep fascia attaching to the bone, forming a compartment. Flexor compartment, deep and superficial. So superficial can expand a little bit, but this deep compartment between the bone, radius, ulna, and the intermuscular septum, this is a interosseous membrane. This is a very, very tight compartment, isn't it? So we have to release this. We have to release the skin, subcutaneous tissue, and the deep fascia. Muscle expands easily so that blood supply distally becomes corrected. That is called as fasciotomy. Okay, guys, we'll end here. It is Hello?
Yes, sir.
Roshan, you are there?